recording. And again, thank you for joining us. I now turn it over to Michelle Shane, Director of Cardiac and Neurosciences Programs at Bakersfield Memorial Hospital, to introduce our speakers. Michelle?
Hi, good evening, everyone. Thank you for joining us. I know some of you have participated with us before, so thank you again for coming back and participating. I hope you enjoyed the wine section, and I hope that you really enjoyed our little charcuterie cup. It's a little different touch this time around. So we are joined this evening by a couple of speakers. Dr. Laura Raghunandan is here, as well as Dr. Rahul Shah, Dr. Normal Singh. Dr. Raghunandan is a neurologist who completed a fellowship in clinical neurophysiology with an emphasis in epilepsy. She relocated here to Bakersfield in late 2019 and joined the United Neuroscience practice. Dr. Shah is a board certified neurologist, and he is the co-director of the Neurointensive Care Unit at Bakersfield Memorial. And lastly, but not least, Dr. Singh completed his internal medicine training at the University of Arizona and also holds a master's in public health. He is currently a hospitalist with the Premier Medical Associates at Bakersfield Memorial. So thank you, physicians, for joining us this evening. And I'm not sure who's going to go first, but take it away.
I guess, hey guys, give me 1 second. Hey guys, my name is Rahul Shah, as Michelle introduced. Thank you for being here, listening to me. Thank you, Dr. Singh and Dr. Raghunandan for joining. Hopefully this is an informative educational session. So, working in the ICU, we've all really, COVID sort of caught our attention for the last, the only thing that's caught our attention essentially for the last year and a half. For mostly unfortunate reasons, but there's just a lot that we're learning from it. And one of the things that's come to the forefront is COVID's association with the nervous system. And predominantly, I think a lot of you guys have heard about COVID's association with stroke. So this being the stroke month, I'm just going to sort of try and quickly breeze through certain things about strokes, the latest updates, and the association with COVID, and then give the floor to Dr. Singh and Dr. Raghunandan. Hopefully we can have a good discussion about it. Everybody over here knows what a stroke is: irreversible brain injury manifesting commonly secondly to any vascular event that basically cuts off blood supply. So I'm going to cut across that. But why does stroke matter in general? Right? It is still the 5th largest cause of mortality in the United States of America. Now that's almost as sad as that sounds. It's actually a good thing, because not too long ago, stroke was the 3rd largest cause of death in the United States. So that's something to be proud of because of the efforts we're putting in, which again reminds people that stroke is something that we can A, prevent, B, we can fix. And I think with better care, we are moving in that direction. But that being said, it is still one of the largest causes of disability across the country and across the world for that matter. Just some interesting facts which probably don't paint a great picture about the situation with strokes in the country and in general the risk factors. 1 in 3 adults have high blood pressure, which is the #1 cause for risk factor for strokes. Very few have it under control. Top 2 causes in heart disease and stroke. Blood pressure is clearly one of the commonest causes or risk factors for those two, and hence just controlling blood pressure across the population would have a great impact. Socioeconomic factors, which I think we cannot ignore anymore. We should never have, and especially in the current setting, I think we need to focus on these more, just to have more of a equality standpoint for how we distribute our healthcare. African Americans, 50% more likely to have stroke, and we can't just blame that to diet or lifestyle. I think a lot of it is secondary to lack of availability of good, adequate healthcare and preventive medicine. Black men, 70% more likely to die of stroke than even non-Hispanic white men. African American women, twice as likely to have a stroke. Just the numbers, again, speak for themselves. And I think it paints a pretty grim picture of how unequal the healthcare distribution and the impact of stroke is in the African American community and also in the Hispanic community for that matter. And I think this is something that we need to focus a lot more on as far as even in our community, which is getting more and more diverse in Bakersfield itself. And I think we can do a lot more towards making sure that the way we provide our stroke care is more uniform across the platform. I sort of wanted to focus just 2 years back, the American Stroke Association released newer guidelines, and I sort of just wanted to quickly breeze by the newer things that it recommends. IVTPA for everybody over here, and I think it's important to just get that refresher. I think a lot of people, we all should be reading a lot of guidelines, but I know from a personal perspective, we sometimes don't. IVTPA is still standard of care for everybody within 3 hours of symptom onset. But that being said, we now know that up to 4.5 hours is standard of care. Previous exclusion criteria were a large stroke, a stroke scale of more than 25, or patient previously having diabetes and a previous stroke, octogenarian, so anybody above the age of 80, and somebody who's on warfarin, irrespective of what their current INR is. These patients were automatically excluded. The latest guidelines actually say that they should not be automatic exclusion, and we can consider. And this is very important because the more people we bring into the basket of giving IVTPA, the less disability we create and the more likely we have of having a better outcome. The most important thing though, and there was a landmark trial, I would urge a lot of people who are interested to take a look at it, is the Wake Up randomized control trial. It spoke about something that we see a lot in the ERs and ICUs and clinics, which is patients wake up with stroke symptoms. And over the years, even in the short period of time that I've been a neurologist, these patients are just excluded immediately because you can never figure out when the stroke symptoms started. But based on this trial, they are recommending these patients to get IVTPA even when they show up, and the last known normal was, let's say, 9 p.m. and they show up at 6 a.m. Yes, they're recommending to go ahead and give TPA as long as from the time of identification of the symptoms to the time of TPA is still 3 hours. Some of the things that people often ask outside of this realm are seizure at onset. The old NINDS trial said that that was an exclusion criteria. It no longer is, as long as you know for sure or can prove for sure that the symptoms are not secondary to seizure itself. Prior antiplatelet therapy, so for patients on aspirin, do not please tell them, hey, there's nothing you can do, definitely eligible for TPA. Coagulopathies, as long as their INR and their PTTs are under control or not too bad, INR of 1.7, which is pretty liberal, we can go ahead and give them TPA. GI bleeding, as long as no significant bleeding in the last 21 days, and other things over here. I have put in a few significant contraindications, but again, there's plenty. But this is more just a sort of overview for everybody out there to just know what we are doing now and what we can do. Mechanical thrombectomy, strongly recommended as far as the American Stroke Association for anybody presenting within 6 hours of symptom onset and not having a large vessel occlusion. Memorial is a 24/7 thrombectomy capable center, so I think, and the only one in the county, I believe. So that makes it all the more significant. The Dawn trial, again, landmark trial that came out a few years back. And this basically showed that up to 24 hours, patients can get thrombectomy and can get significantly better outcomes as long as they meet certain criteria. And I won't bore you all with those specifics, but the point being, if somebody's having acute stroke symptoms, they're better evaluated in a stroke center that can then make that decision if they have any possibility for treatment. Antiplatelet therapy, the newer guidelines actually do recommend dual antiplatelet therapy for up to 21 days and then subsequently monotherapy. Again, something that's very commonly asked by a lot of hospitalists, primary care physicians, that they ask me these questions. And what we are often doing is putting patients on dual antiplatelet therapy for up to 3 months, just because of better compliance and then taking them off as long as there's no severe bleeding issues. And then again, stroke units have been shown in multiple research studies to improve outcomes, stroke units, neurocortical care units. So now coming to the most important thing that we all sort of want to talk about, and I'll try and make this sort of quick based on what we are seeing out in literature, out in the world, having spoken to a lot of my colleagues around some of the stuff that I've seen. Yes, strokes are far more common in COVID patients. Up to 7.6% increase in strokes in COVID patients based on just the literature we're looking around at. Obviously, the numbers will change. We have to take into perspective the fact that a lot of developing countries are not testing every patient that comes in. And I personally know 30-year-old, 35-year-old friends of friends in India that have had massive strokes with no risk factors, and nobody knows if they were COVID positive or not. So I do know that these numbers will change in either direction. And I think that's something to keep in the back of our head and look at all these numbers with some perspective that we're still so early in this crazy pandemic. And I think we're just going to find a lot more. So proposed mechanisms, you all have heard this term, hypercoagulable state throughout COVID. I think everybody's, and cytokine storm, those were probably the two most trending terms, I think, sometime last year. But yes, those are the hypercoagulable state from the systemic inflammation and the cytokine storm are known to increase the chances of clots. Post-infectious immune-mediated response, and this term is significant because it's also sort of postulated to be the cause for other neurological manifestations. And I know Dr. Raghunandan is going to speak a little bit on that as well and her experiences with that. And then direct viral-induced endothelitis. We know that other viruses like HSV do cause these. And so COVID has been known to cause these as well. And autopsy specimens from patients have shown that this is definitely a case. Furthermore, some of the things, all the risk factors that we heard for patients who get sicker with COVID, hypertension, diabetes, obesity, those are risk factors for stroke in general and all cardiovascular disease. So that kind of goes without saying that those things, why we are seeing higher incidence of strokes in these and cardiovascular diseases in these same patient populations. And then we can't ignore the socioeconomic factors that are playing a role. Last year, more sedentary lifestyles, higher stress, far greater consumption of alcohol. I think most people on this chat are probably can probably raise their hands to that as well. But greater intake of fast food. I just read an article which said that fast food industry is one of the few ones that actually has made a better profit in the last year. And then fear of infection, the biggest thing I think that a lot of the primary care physicians on this chat will probably agree with: less PCP visits, less follow-ups, missing prescription refills just because things are closed down or people are just afraid of going out in public and stuff. And I think that has resulted in a lot of people's health taking a turn for the worse over the last year, not just from the COVID itself and the stress itself, but these sort of after effects that we're seeing. And so what does the literature say so far about this association of stroke and COVID? Incidence of large vessel occlusion and simultaneous involvement of multiple vessel territories seems to be far more common in COVID-19 patients than your regular strokes. And this is significant because when you're talking about large vessel occlusion, like I mentioned below, the severity of the strokes is also far greater, which also means the disability or mortality from it is going to be far, far greater unless they receive the right treatment. Also, you typically don't see multiple vessels included, large vessels included at the same time. And so this is something that on a common basis, and we're seeing a lot more of that. Dr. Thomas, our interventional surgeon, I was speaking to him, and I believe just at St. Louis Obispo, he had a 40-year-old patient with bilateral middle cerebral artery occlusions. That's something I've never even seen in the last few years that I've been working ever. And then this patient, this 40-year-old, had obesity, but apart from that, the only other risk factor was that he was COVID positive. And so just really bizarre sort of presentations that we're seeing with COVID. Ischemic strokes are more common. That being said, a lot of patients are being put on anticoagulation. So they are having hemorrhagic strokes later on during their admission while we're caring for them for their respiratory illnesses. I've personally taken care of a patient that unfortunately didn't survive last year, that was transferred to me for a hemorrhage after she was placed on a heparin for high D-dimer levels, etc. The other aspect of this is mortality rates with COVID-19 patients who had previous strokes, nothing to do with current strokes, is significantly higher. So something to why these patients need to be even more careful and carry out the precautions that the CDC and everybody else is recommending, and obviously vaccination, right? Why these things are significant, because if you had a stroke and you then get COVID and you get sick from it, you're 3 times more likely to die from it than just a COVID patient who had no previous strokes, and that's significant. Now, one of the things that's scary, and you guys have probably heard some of this, is these big strokes happening from nowhere in young patients who do not have any major symptoms. And I would not want to bore you guys with multiple. There's so many studies and case reports mentioning this, but obviously New England Journal of Medicine, one of the most respected, probably the most respected journal. And this was early on during the COVID time, I think last year, and this was published in May. And they had a series of 5 patients, all below the age of 40, within a 2-week span, all with large vessel occlusion, and only 2 of them had a hypertension. The rest did not have any major risk factors, and all of them with massive strokes, and prior to that, they probably saw 0.7 patients under the age of 45. So not even a single patient per couple of months. So to give you guys perspective, 5 young patients with large vessel strokes with no risk factors in a space of 2 weeks. And that's just in one center. There's countless case reports and case series mentioning these things. And that's sort of what I'm mentioning. And this is again why I think we as providers and medical personnel, it's important for us to sort of spread that word around as well, that you may not have risk factors, but COVID can cause major issues even in young individuals. Now, quickly, I guess the most important thing is the diagnosis or way of diagnosing it or management any different than how we would approach a regular stroke? The answer is no. Obviously, if they have COVID symptoms, we take care of those, but the stroke treatment goes on the same way. They're still candidates for IVTPA as long as they meet all the inclusion criteria. They're still better served at a designated certified stroke center or in a good higher level neuro ICU. And if you all have colleagues in neuro ICUs across the country, neuro ICUs have been in the forefront of handling a lot of COVID patients across the country. For these reasons, and because we are technically still an ICU, and so we should be able to handle all of these. Low threshold for working up for COVID in patients, even on the outpatient setup. So if you have a patient that shows up with a DVT or something, test them for COVID, and then also do a hypercoagulable workup and see if they are higher risk and if they need to be immediately put on anticoagulation. One of the other things that I noticed personally over here was initially there was so much focus on the ventilators and the ARDS and whom to ventilate and whether to use non-invasive and just the respiratory aspect, that even in our hospital, which is a stroke center and a neuro ICU, the neurologist and the neuro part was sort of put aside a lot initially. Patients were put on such high sedation because of the level of agitation. And I noticed that we were called in eventually after 15, 20 days when the patient is already stroked out, already brain dead. And I personally have been consulted for so many patients who had that. So I think going forward, now that we don't have the fear of big surges, and hopefully we can avoid that, we can probably do even better diligence towards some of these patients that come in and keep a closer eye for these neurological sort of deteriorations, as I would call it. Post-stroke, greater significance of rehab facilities. A lot of these patients are younger. So remember, guys, everything that somebody like myself does or anybody else does is initial, but after that, all a patient needs is encouragement, motivation, social support, and rehab. That's it. No aspirin is going to make them move their arm better. It's essentially rehab. And so I think we need to focus on those things. close follow-ups, more aggressive risk control, because once you have a stroke, your risk for having another stroke goes up significantly. A lot of these patients have a tough time being compliant with medications and stuff. So please, we all need to sort of chip in to make sure that that happens. And increased awareness, vigilance in COVID-19 populations, to let somebody know that they may not have significant COVID symptoms, but if they're positive, they could suddenly present with a large stroke, and that they should still use the same sort of the fast assessment and everything else that you would do for stroke, that somehow stroke care does not get excluded if you have a stroke when you're COVID positive. And that's probably, if we took nothing away from this talk, I think that's the biggest take home, that we can still save these people's lives and neurological function the same way we would do. So yeah. And then again, Dr. Raghunanan will, I think, speak a little bit more on these. And, obviously we're focusing on stroke today, but there is, COVID is presenting with a massive range of neurological symptoms and features and diagnosis, some of them almost baffling, even something a few months later as Guillain-Barré. And I know we probably have a few hospitalists over here and primary care physicians, and this is significant, I feel, because y'all can keep an eye on these things when patients come to you. They might have had COVID 4 months back and suddenly. So I think, it's important to keep these in the back of your head as far as when these patients come, and if needed, send them over to a neurologist immediately, because yes, we are seeing a lot more of this late neurological presentations in patients who had COVID previously. And I think, we're just seeing we're just at the tip as far as identifying all these random things and COVID's multiple faces, as I would like to call it. And, even the neuropsychiatric manifestations are massive, and we every day there's new literature and we're finding out more. So hopefully we are better prepared for some of these, and we can give these patients care that could save them. And then no disclosures. Literally, as I said, I got a box of nuts and cheese for doing this. But thank you guys. Thank you for having me, and I'll pass on the baton to Dr. Singh and Dr. Raghunanan, and we can probably have a chat about this or entertain questions as we go forward.
All right. Hello, everyone. This is Dr. Singh. I think I'm on the receiving end as the first contact with the patient. And I think I would like to hear the specialist first. I would like to have Dr. Raghunanan go ahead. And I have a couple of questions, what probably my primary care physician friends would have. So I think we can open up that later on. I will have Dr. Raghunanan go ahead.
Give me 1 second as I organize my screen. And can you all see that all right?
Yes, ma'am.
Awesome, thank you. Well, I wanted to say thank you for the opportunity to participate in this discussion. It's my pleasure to go over some of the neurological complications of COVID. First, I wanted to share the scope of the problem, and I think it's best summarized with this slide. This is a website out of the Johns Hopkins University Coronavirus Resource Center, and I took this picture, I screenshotted it on May 3rd. And as you can see, it's a global problem. The United States is here. All the red dots or centers are areas of COVID hotspots. You see the number of global cases at 153 million, global deaths 3 million, total test results in the United States. And it just tells you that this is such a global problem. And the issue with this slide is that this could be an underestimation of the actual numbers, because for a person to be counted on this figure, they'd need to have a positive test. And so just to briefly just go over how I'm going to discuss my presentation. It'll first be a summary of a brief timeline of events, and then I'm going to talk about the post-acute COVID-19 neurological symptoms that is often seen by the hospitalist, the neurointensivist in the hospital setting. And then I'll go on and discuss the post-acute sequelae of the COVID syndrome, otherwise known as PASC, and these are mostly in the non-hospitalized patient. And they've been termed the long haulers because they have persistent symptoms for such a long duration of time. So per timeline, on January 29th, we started noticing symptoms, and this is a paper out of one of the first papers out of Wuhan, China. It consists of 214 hospitalized patients from January 16th to 19th. And what it shows here is an acute stroke and a CT of the patient. But then also in this red box, it begins to discuss the neurological symptoms that people had at that time. It included muscle ache, confusion, and headache. And then later on, neurologists combed through that data of 214 patients, and they wanted to break it down even further based on their neurological symptoms. And they noticed that two entities highlighted here in the red box are really what was predominant. And that includes impaired consciousness, as well as what Dr. Shah mentioned, which was the acute cerebrovascular disease. And then also to touch base on, or just to mirror what Dr. Shah said as well, is there was a case out of the New England Journal of Medicine in May 14th, 2020, and it was a total of 5 patients. And the most concerning thing about that study is that 2 of those 5 patients, their main presenting complaint was their stroke. They didn't have the typical findings of coronavirus, but they did test positive, and the stroke is really what brought them to the hospital, and that was really their only symptom. There was a larger study in October 2021, a larger nationwide surveillance study out of the UK. This study consisted of 153 patients, and breakdown here, male versus female versus age, and what their percentage of symptoms were. And by far, the most common symptom that they presented with was 2 different categories. They grouped it again into stroke, as well as neuropsychiatric symptoms. And this neuropsychiatric basket includes encephalopathy, delirium, psychiatric presentations such as psychosis and depression. And they saw that the neuropsychiatric symptoms were more present in the younger population, whereas strokes were more present in the older population. But these 2 symptoms were seen across the spectrum, affecting both the young and the old. Here's a further breakdown of that UK study showing the cerebrovascular events consisting of 62% of them, and then the breakdown, they're ischemic, intracerebellar hemorrhages, vasculitis, and based on the altered mental status changes, 31% of the patients had that, and it was either encephalitis, which was 18%, encephalopathy, not otherwise specified, and then just that cluster of neuropsychiatric conditions. Later on, this study came out of the United States. It was a pretty big study out of Northwestern University. It consists of 10 hospital systems that I believe it was 10 hospital systems, and I forget how many centers were involved. But the number of patients that the study went over was a total of 509 patients. And of those, 419 had some sort of neurological manifestations. And by far what they noticed is 347 of those 509 patients had acute encephalopathy. Then they went further and they looked at risk factors, and they noticed that those patients with the most severe COVID-19 disease also had the terrible acute encephalopathy, but they also noticed other risk factors like a history of neurological conditions, as well as chronic kidney disease. And these were predisposing patients to neurological manifestations of COVID. When you look at the breakdown of what symptoms they actually had, we see myalgia, headache, dizziness, dysgeusia, anosmia, and encephalopathy. They also had generalized fatigue. And then this is a breakdown of symptoms that they may have had at any time during the course of the disease. We see encephalopathy being a huge symptom, as well as headache and myalgia. There are other conditions too, but those were rarer. This study said ischemic and hemorrhagic strokes, movement disorders, ataxia, peripheral nervous system disorders, and seizure. And this again is the study out of Northwestern University. I just wanted to highlight the numerous types and amount of research. And as Dr. Shah said, that there's so many papers out there. But I wanted to focus on a research paper out of a huge retrospective study out of the Global Consortium Study of Neurologic Dysfunction. And I'm going to just show you a timeline of things that started happening. The first reported case in the United States was around February 29th. And then the US declares a national emergency. There were a group of neurointensivists. It started off as a small group of people who wanted to prepare their ICU. And then that study grew. And fortunately, it turned out to be like a global study. The US is the main participant, but it's not the only participant. So it's nice there are European allies and Latin American allies that will share their results. And this is just a brief breakdown of the 3 cohorts that participated in the study. The energy registry are from the European allies, and the GCS NeuroCovid, both of these 2 groups are from the United States predominantly. The COVID neuro group are those patients who had neurological symptoms, and these are patients with or without neurological symptoms. The difference between the energy registry, which is out of the European Academy of Neurology, was that a trained neurologist verified the symptoms. This is a breakdown of the data, which part of the world was represented in the study, the sex, as well as the race. And as Dr. Shah mentioned, the underlying conditions that were noted of those were pre-existing neurological conditions, and we can see 45%, 36%, and 23%. Also noted, and I didn't mention this earlier, but Dr. Shah did, hypertension and diabetes were definitely risk factors as well. We can see also that about a quarter of the population were mechanically ventilated in all groups. And that by definition is severe COVID. And we can see here that there was a mortality associated with the severity of COVID. Here's another breakdown just based on symptoms and percentage. Again, we're seeing encephalopathy being a main presentation, but there are other things too. Coma and stroke is here if you want to see where it fits in the list of symptoms, as well as seizures and meningitis and myelopathy. And then just a brief overview of what they meant by encephalopathy: altered mental status, agitation, dysexecutive syndrome, once again, commonly seen in the severely ill and associated with diabetes and hypertension. And these are the patients that are, of course, most times in the ICU, but then also have multi-organ system dysfunction. On CSF studies here, they did not see any pleocytosis. No virus was detected in the CSF by RT-PCR. On the MRIs, usually they would see white matter changes or punctuated microhemorrhages, and EEG usually showed slowing. If you would look at the pictures of these patients, this is the author and this is the study, but this is pretty much some of the MRIs that we were finding in those patients who were severely ill, and mechanically ventilated. And as Dr. Shah went over, strokes were definitely one of those, and it had a pretty strong presence. About 20% of the patients that had COVID, that had of all the neurological symptoms, sorry. And the breakdown of the strokes were predominantly ischemic, as Dr. Shah mentioned, hemorrhagic, and then venous. More commonly seen in the older adults, but yes, seen in the younger ones as well. And more of a hypercoagulable type of pathology. And they termed it sepsis-induced coagulopathy. And in this type of setting, they would see a lot of anticardio or phospholipid antibody positive patients. And the underlying mechanism was predominantly endothelial injury via the ACE receptors that are lining the blood vessels that are in the brain. This puts seizures on the map as well. This is a breakdown of the signs and syndromes, male versus female, and then by the age group. We see of the acute encephalopathies, that it is 33% in the less than 40s. And as you go across the age group, you'll notice that more people are presenting with acute encephalopathy. The number here is 74% in the greater than 80 age group. When you look at strokes across the board, you'll notice that those patients that are less than 40 years old, there's a 1%. And as you go across the age spectrum and patients over 80, you'll see a higher percentage there. This is an in-hospital mortality assessment, and they're trying to point out that risk factors such as acute encephalopathy, when patients present with that in the setting of a positive COVID test, that there's a 6-fold increase in mortality as a result of the patient having encephalopathic symptoms. Coma, you would see next. And then oddly enough, those patients who had anosmia or ageusia, they had an inversely associated mortality, potentially suggesting that patients were well enough cognitively to be aware of these symptoms and its manifestations and report it. And this is a breakdown of that global consortium study, that the main presenting symptom was acute encephalopathy at 50%, coma at 17%, and strokes at 3.1%. And that there was an increased mortality associated with these symptoms, a 6-fold increase risk of death, specifically for acute encephalopathy, and other risk factors for COVID-19 include age, male sex, white race, and a pre-existing neurological disorder. So the next study that I want to talk about focuses on the outpatient side of things. As a result of everything that was going on in the world, there are quite a few centers that formed these neuro-COVID clinics, where they specifically address patients only with COVID positive test or COVID symptoms. One such study was out of Yale, and these are the patients' complaints by percentage. Cognitive impairment was one of the higher percentage, as well as neuromuscular myalgia, headaches, anxiety, depression, sleep disturbances was a huge part of it. Because not only are they feeling fatigued, but they also have difficulty sleeping. Dysautonomia was also noted there. They also noted that of these patients, they noted that 2/3 of them were never hospitalized during their acute illness, suggesting that even mild COVID-19 may lead to long-term sequelae. This was the neuro-COVID clinic out of Northwestern University. This opened in May 2020. It first started as just telehealth visits, and then they opened up to in-person visits as well. And it initially just included one physician and a neuroimmunology fellow, and then it expanded. It was a prospective study of 100 consecutive patients from May to November 2020, and it was either physician referral was not required and positive tests were not required, but they did break down the study based on positive and negative COVID-2 tests. Their inclusion criteria included non-hospitalized patients and those patients who had neurological symptoms persisting for more than 6 weeks. This is the breakdown by age. You notice that the mean age was 43.2%. And then when you looked at the percentage of people, the percentage of neurological symptoms, you'll notice that brain fog and that cognitive impairment is pretty high again on the list of symptoms that people complained about. Headaches were there, numbness and tingling, myalgia, dizziness, blurred vision, tinnitus. Again, seen on a different study was anosmia. This one was blurred vision, but for those patients who tested positive with SARS-CoV-2, they were aware of their symptoms, whereas those patients who did have neurological symptoms but tested, unfortunately, COVID-2 negative, so they thought potentially it was a false negative, they noted that they were able to report symptoms of anosmia and blurred vision, again suggesting that they weren't sick enough to be hospitalized in the patient, but they were aware or alert enough to be cognizant of their symptoms. Fatigue, again, is one of the long hauler symptoms that we commonly see on an outpatient basis as a result of COVID-19 infections. And then the conclusion for the non-hospitalized long hauler patients, that these patients have prominent and persistent brain fog and fatigue in the long haulers patients. They have impaired quality of life in areas of cognition and fatigue. They have impaired attention and working memory. There is a diagnostic dilemma because these patients will have neurological symptoms, but they'll have a negative SARS-CoV-2 test. In the Northwestern study, they noted that there was a higher female preponderance in the sequelae COVID symptoms, and that the time of onset is not a good predictor of recovery, and that most people just need a little, just have to wait on time in terms of recovering from their symptoms. And that is the end of my discussion. I will switch to Dr. Singh, but I wanted to say thank you to all the people who were participated in this discussion.
All right, thank you. I think both the presentations were awesome. And I think Dr. Shah and Dr. Raghunanan has covered almost everything. I don't want to repeat those things. Given on a receiving end, because we see the patient in the hospital setting, I have a question, and then I will leave to my primary care physician colleagues to bring on their questions, what they see, and what are their questions, especially to the neurologist. What we have seen is, I totally agree with both the presenters. What we have seen is most of the cases I have seen, they were pulmonary emboli patients. And after that comes few strokes and one patient of acute coronary syndrome. And especially for initially when we were using the single dose or low dose Lovenox in a patient who presents with a COVID with the hypoxia and becoming encephalopathic. And then the study came up showing that if the D-dimer is above 1,000, then we can use, it's advisable to use the prophylactic dose of Lovenox or heparin to prevent the risk of PEs. I have 3 patients I remember. One patient had a directly presentation from the ER that had a left-sided weakness, and we found on the MRI that was small ischemic stroke. But 3 patients in the hospital, patient been in the hospital for over a week and hypoxic and became confused, encephalopathic. And then we ruled out all the causes. Eventually we ended up doing the MRI. Then we found that there were small infarcts, multiple infarcts, and no evidence of any cardiac event or AFib as such. So in these patients, we run with the dilemma, should we go with a therapeutic Lovenox, or should we just do the DVT prophylaxis, like single dose, what we've been using? Is there any screening tool, like we have this much level of D-dimer and non-neurological clinical feature? What should be our approach?
Dr. Singh, I personally, I'm not sure of there being a specific sort of cutoff per se. And the D-dimer levels are the one thing that has been shown to be elevated in almost 100% of the patients that have been seen so far, especially the ones that get sick enough to be in the ICU and stuff. But I'm not exactly certain, and maybe my personal knowledge might be lacking, but I'm not certain if there is a direct correlation that they've seen with strokes per se, saying that, oh, at this level, they're having strokes, or at this level. Now, that actually is a very valid point, because I'm pretty sure that could be there might be some study coming out that actually looks at that. There's so many ICUs across the country and across the world have collected data on these things. So I don't think that's something that would be difficult to extrapolate from all that data, but I don't personally know of anything.
Sure, thank you. I think given the brevity of time, I would like to bring on my primary care physician colleagues. If they have any questions specifically to the specialist, please.
We do have a couple questions in the chat, so we can start with a few of those. I do see one here that says for patients being discharged with COVID, with patients being discharged with COVID, be discharged on DAPT or therapeutic anticoagulation medication.
Do you guys want to take the question or do you want me to answer?
Go ahead.
So that depends on the situation. If they have concurrent, I think I briefly mentioned this in my slide. If they have DVTs or PEs, or any major AFib, then yes, they need to be on anticoagulation. But apart from that, again, if they don't have any of these, then just regular antiplatelet therapy, the way the guidelines would suggest for any other stroke.
I'll agree with him. It depends on what the reason for putting them on something. If it warrants DAPT, we'll do that. And if they need to be on a stronger therapeutic anticoagulation, it's a case-by-case basis.
Thank you, Dr. Raghunanan. We have another question in the chat box. Is there a chance, and I'll put this out for whichever of you would like to answer it. Is there a chance that post-COVID patients may suffer from less profound cognitive deficits when presenting to their primary? And if so, what should they be looking for?
So what we usually see is the time is one of the best healers, unfortunately. But it's not always the case. So a lot of people will present to either PCP or outpatient neurological clinics with cognitive fatigue, cognitive brain fog is what a lot of people say, cognitive clouding. In one of the papers out of Italy, they did PET scans on about 20 patients, and they noticed that there were hypometabolism in certain areas, and those patients were also COVID-19 positive, and they trended it. And one of the things that they noticed was time was one of the most helpful things. What I still like to do is encourage patients to have cognitive training as a physical therapy, just so that they're engaged, because the other thing that happens is because of COVID, patients are mostly like stay in their house. They don't really engage with other people to minimize risk factors, but helping the road to recovery would be helpful if patients had physical therapy for cognitive-based training. I don't know if Dr. Shah has anything he'd like to add to that.
No, I think I would agree with Dr. Raghunanan on that point.
And in some patients too, they've noticed certain medications, some stimulants might be helpful, something like amantadine. It's an activating agent. That's been shown to be helpful in certain scenarios.
So this is a great question, and I'm going to direct it to Dr. Singh. For patients with diabetes, should they have cardiovascular protectant medications to reduce their risk for stroke? Yeah, specifically the DPP4 inhibitors.
There are recent studies, yes, especially for the cardiovascular, as a cardiovascular protection, yes. And this is for the stroke, I'm not completely sure, but if I think if we go with reducing the cardiovascular risk factors, and there are a lot of good studies, especially with the DDP4 and the SGLT2 inhibitors as well. The recent studies coming up with the cardioprotective role, and especially with the diabetes patients and heart failure patients.
Thank you for answering that. I think that's really important for our population, especially here in Kern County and those that we see with diabetes. So at this time, I don't see any other questions in the chat box. So I think I will hand it back over to Patty because I'm pretty sure she has some information on some future talks and other presentations that are in the pipeline.
Awesome. Thank you, Michelle. And I asked one simple question too, something for Dr. Singh really quickly. I know we're getting close to time, but Dr. Singh, are you seeing other interesting presentations outside of stroke for post-COVID diagnosed patients?
Definitely. So main presentation we have seen was pulmonary related to the lungs, especially patient with the hypoxic respiratory failure, and not so actually with the patient with asthma or COPD, but those patients were non-COPD and non-asthmatic patients presenting with hypoxic respiratory failure and they had a diagnosis of COVID pneumonia, most of them. Few of them had PE and few of them had DVT and pulmonary embolism. Apart from that, only very few patients I have encountered personally stroke, as we discussed, and mostly morbidly obese patients, diabetic patients, especially in the early studies, they did not include a lot of diabetic patients, but it was totally opposite. In our scenario, we have seen if we run the studies and see the retrospective analysis of the patient we have seen in the hospital, we'll be surprised. Three things that comes to our mind is first is non-asthmatic and non-COPD patient. Two is morbidly obese patient with no past medical history. And the third one was their diabetes. And if we talk about ethnicity, more than 60% of patients were Hispanic in origin. So these were the common theme we have seen early on when COVID started in March or April or June.
Okay, awesome. Thank you so much. And I did get one more quick one that was a direct message to me, and it says, upon discharge, what is the best way a PCP can manage a post-COVID patient and protect them from stroke and neurodeficit? I'll open that up to the entire panel, whoever wants to take it, and then we'll go ahead and close.
Laura, maybe you might be best suited for that on the outpatient setting, I think.
So earlier on in the course, we saw that even though the literature I presented showed that people who had COVID-19 positive tests or COVID symptoms, the most common type of stroke was ischemic stroke, but we also had hemorrhagic strokes. It's probably best that they follow up with a neurologist. And the reason I say that is because it's a really fine line. Sometimes you'd have patients and you'd put them on aspirin and then they'd have terrible strokes that they otherwise wouldn't have had if they didn't have COVID. And then sometimes we have patients who they're high risk, and even before, or if you plan on getting them the COVID vaccine, for example, like let's say an MS patient, if you are concerned about their risk of coagulopathy, we would put them on an anticoagulant for 2 weeks, for a month or so, just to cover them during that period, because they would be high risk based on their other risk factors. So it's hard to just generalize and say what would be the right answer for somebody. We usually look at all the other risk factors that may play a role in the decision to put them either on aspirin, dual antiplatelet therapy, or a NOAG. And of course, if they had a stroke, something like lupus and or positive antiphospholipid syndrome, clear cut, yes, we're going to put them on warfarin if that's what they need. But a lot of it is a case-by-case basis, unfortunately. I don't know if Dr. Shah has anything else he'd like to add.
It's good. Okay, thank you so much to our physician panels for providing such valuable content and for the questions from our physician community. It's always great to hear from you as well and have just such a robust discussion. So we just thank you so much for that. And in closing, I want to share an upcoming event. If I can get it to do slideshow. There we go. There we go. So on May 20th, we're going to have a second stroke-related education with Dr. Kieran Thomas and Dr. Sarah Hanari. This one will be a case study on emergency and preventative treatment, including a patient testimonial. So please RSVP for that. And In addition, we'll have some other educations coming up, as you can see here. June 24th, there's one on Watchmen. We have AFib coming up in September. These are all physician facing. And then some other topics of discussions you can see in the box there that we may bring forth in the future, but just reach out to your MDR for more information on any of those. And with that, from all of us at Dignity Health and the providers organizations, thank you so much for joining us. If you have further questions or have patients who could benefit from a consultation with a general neurologist regarding anything you've heard tonight, please reach out to Bakersfield Memorial Hospital Neuroscience Institute at 661-632-7126. That concludes our event. Thank you so much and have a great night.
Thank you, everyone.